Welcome. I'm Brian Lowery, professor at the Graduate School of Business at Stanford University, and this is Leadership for Society, the Race and Power series. And today we're talking about health equity and race. And my guest today is Toyin Ajayi, and she is the Chief Health Officer and co-founder of Cityblock Health, a New York-based health and social services company. Thanks for joining us, Toyin.
Thank you for having me. It's really nice to be here.
Great. So let's jump right in. We can't talk about health without talking about COVID right now. And the disparities in health outcomes have been stark, right? There's been a lot of conversation both about differences in rates of infection and also differences in mortality. Can you give us a sense of the magnitude of those differences?
Yeah, absolutely. This has been deeply well reported across every part of this country. When you look at adjusting for age, adjusting for comorbidities, so underlying medical risk factors, Black and brown people are orders of magnitude, sometimes 3 to 6 times more likely to die of coronavirus than white counterparts across the entire country and throughout the experience of this COVID pandemic. It's profound and it's impossible to ignore.
Mm-hmm. When I hear about these disparities, there's often discussions about how they might be driven by biological differences, right? So I was recently in a chat, in one of my professional chats, where someone pointed to racial differences in lifespan as the biggest indicator of racism in this country. And someone else responded that we should ask questions and explore other reasons for these disparities. Why do you think there's such interest in finding non-racial explanations for these types of disparities?
Yeah, I think it's really uncomfortable to recognize what the data show us and have shown us over and over and over again, which is that race as a social construct does not independently confer increased biological risk for poor health outcomes in the ways that we're seeing it, but that racism as a mechanism by which that social construct transmits risk and prejudice and bias and risk factors is a powerful and potent independent risk factor for these disparities. Mm-hmm. And saying that out loud and unpacking it and then like reckoning with what it means is really hard. And so there is this just like desperate bid to find some other reason to make it so. Call it socioeconomic status, call it behavior changes, call it comorbidities, which is a sanitized version of the sort of upstream sequelae of all of these problems that we're talking about. Mm-hmm. It's very hard to look ourselves in the mirror as a society and recognize that we have created a construct out of nowhere that in and of itself, we have given the power to determine who lives and dies in our country.
Yeah, when I think about this, I've read a little bit about it. One of the things that strikes me most is a study that found that kids that come in with long bone breaks are less likely to get pain care if they are people of color, children of color. So when you think about it, you do much more. Obviously, this is where you live, the work that you take on. What are the things that are most striking to you when you want people to understand in a clear, profound way the depth of the problem? How do you convey it to them?
So that's a really good question. There are so many ways to tackle this, right? So that very poignant example that you cite is reflected in the data over and over again. It's a reflection of individual bias, where people have sometimes it's implicit. They don't even know that they have these like fixed beliefs that they ascribe to a certain race that lead them to behave and treat people disparately. So we believe that Black kids have a higher tolerance for pain than white kids. We believe that they are more likely to behave badly or disrespectfully, and therefore more likely we're not surprised when they are more likely to be censored in school. Those are sorts of things that underpin the ways that people have formed attachments to this construct of race and act on the basis of that. But I'm also really compelled by data and evidence that's even further upstream that shows us very much how this construct has been fabricated. And so there's a study that Dr. Kamara Jones, who is prolific in this space. She's a family physician, an epidemiologist, and just a brilliant thinker in this space did, where she looked at people who identify as Hispanic, but who present as white, and who are perceived by the outside world to have a different sort of identity than perhaps the one they believe of themselves and their heritage would reflect, versus people who are identified as Hispanic. And what she found was that your health outcomes are much more correlated in your health experiences with how the rest of the world sees you, irrespective of what your ethnicity and lineage is. And so take that example and really sit with it, right? Like, how can you not believe, therefore, that the construct of race and the way that people behave and the way that our society treats groups of people based on their race in itself is a risk factor and a driver of health outcomes? That's really like, it just, you can't not kind of, you can't fail to see what's held within those data.
Yeah. And so you've already pointed to a number of things that could drive these disparities, right? So one of the things you said was implicit bias in terms of the way people are perceived. Like, for example, in the example of kids, they are perceived to have higher pain thresholds. And I believe that's true across the age span. What do you think are the biggest drivers of racial disparities in medical outcomes? If you were to point to, I don't know, 1, 2, 3 things as like the biggest issues, what would you point to?
Yeah, I think it goes further upstream. By the time that we are showing up in the healthcare system and experiencing implicit bias, we have already accumulated all of the risk factors associated with where we are allowed to buy or to live, to buy our homes and to live, the schools that we have access to, the places that we are able to walk through, the way that police have interacted with ourselves, with our family members, with other people in our community. And so those social factors, there's a big sort of movement in healthcare to talk about social determinants of health, to really start to unpack and recognize the impact that where you live, work, play, go to school, your access to healthy, nutritious food, how much education and what types of education you're exposed to, how that all drives your health outcomes. What we recognize is those social determinants also reflect an inherently racist system that disparately assigns and distributes social goods to people, and then those social goods impact their health outcomes. And so I think, it's really, really important actually for us to understand that the causal link between racism and racial bias and health outcomes starts way before a person even falls ill. It starts in all of the factors that then predispose them to illness. And then we further perpetuate it when they interact with the health system, and they are then disparately treated when they interact with the health system. So I would go way, way, way upstream to the social drivers.
Got it. And when you start talking about going upstream, one of the things that people point to are individuals make different choices, right? So this is a big part of the conversation, even and to some extent among, as I understand it, among health researchers. Like, how do you think about the choices people make about activity or about eating habits? So what place do you assign personal responsibility? So, because the things you're talking about don't really have, it's about the environments we inhabit, not about the choices we make. How do you think about personal responsibility in this situation?
Yeah, no, I ask people to do two things. So we can talk about it from an intellectual perspective. We can talk about the studies that have started to try to quantify the cognitive burden of poverty. So what does it mean to your ability to make choices when you spend all day negotiating for food and rent and a safe place to sleep at night? Even the idea that we can make informed choices that are forward-looking into the future is a privilege. Because for many people, they're truly like physiologically depleted by just how hard it is to survive on a day-to-day basis. So we can take it in an abstract way, but these are human beings. Let's talk about human stories. So let's talk about the choices that that a mom raising a few kids in a low-income community with a Black son whose health and well-being she's worried for on a daily basis, with a very fixed income. What choices can she make when she has a choice between trying to get as maximum calories into her family as possible for as few dollars as she can, recognizing that if layoffs are to happen at her job, she's more likely to be fired, recognizing that if she has a financial crisis, she has no rich uncle or cousin or brother to call on, recognizing that her landlord would look for any excuse to evict her, because having a non-Black person in that home increases the property value. Like, what are we actually talking about? And I would love to see the experiment that controls for all of those things and then offers people choices about how to invest forward into their future, how to make decisions about providing a stable basis for their families, about accumulating wealth and health. I think we'd make the same choices if we had them. And I continue to reject the notion that this is somehow mediated by simply people making bad choices. The choices are constrained from the get-go.
Yeah, I mean, I always find this conversation really tough because I think people have a hard time understanding the difference between individual choice and social context that affects individual choices. And so I always find this a really complicated thing to account for, leaving people the room for individual agency and responsibility, and simultaneously understanding when you look at group outcomes and group differences, you can explain group differences as a function of aggregate individual choices, right? Those group differences, like there's what makes those people the same is how people see them, not the choices those people make, right? And so if you see differences in choices at the group level, it has to be driven by social forces, not individual level choices. There's something about that seems really hard to hold on to, right? I think people really like to make these individual choice explanations, or give these individual choice accounts for these differences. So I hear you on that. It's tough. Like, what are we talking about when we're talking about these group differences? How are people supposed to live when they're as a group facing these large social forces?
Yeah, and you also have to wonder, who's asking the question and who's telling the story, like whose narrative is it, right? And so, again, this is just humans, especially in such an individualistic society as our kind of collective U.S. society is. People like to retell their stories as having entirely to do with their own graft and hard work and grit and determination. That is the American dream, right? And so the folks asking this question themselves believe that they have achieved whatever status and whatever success and whatever health through their own efforts. Therefore, why can't others, right? This sort of pull yourself up by your bootstraps, I did it myself, takes away the burden of having to recognize and acknowledge our individual privilege, which detracts somehow in people's minds from the work that they did to get where they got to. And therefore undermines a narrative that would allow us to think about what our obligation is to other people and how our choices constrain other people's choices, our individual choices. So it's a convenient narrative, I think, for folks who find themselves in power and with the ability to tell that story.
Yeah, it's nice to talk about individual responsibility when things have worked out okay for you, right?
Yeah.
Yeah. So given all this, these are not new problems, right? These problems have been around as long as this country has been around. Arguably, people have cared more about it more recently, but what has been done to address these huge disparities?
You asked me the question I can't answer. Look, we're talking about it a lot. So
I know we're talking about it. I didn't say what are we talking about. I said, what are we doing?
Do you give A grades for effort in your classes? I don't know. We're talking about it a lot. We've been talking about it for a really long time. And this is an area in which, despite, I think, a really clear recognition, very compelling evidence of what the drivers are, we've not made anywhere near the progress we should have. It is totally unacceptable that we went through this COVID pandemic and rediscovered the same stuff we've already known. COVID-19, like every other disease category, has disproportionately impacted communities of color. And it didn't have to be that way. We today in 2021 continue to see that, that the mortality gap and the morbidity gap between Black birthing women and white folks, when you adjust for everything, income, when you adjust for educational status, is massive and has not changed. So, I see a lot of effort, I see a lot of conversation, but the facts tell us we have not made any progress. And it's in some pockets not for want of trying. There's been a lot of effort, particularly by some really incredible scholars and activists in this space. But we as a system collectively have not mobilized behind the notion that health equity is a fundamental challenge that we have to take on in the healthcare and social systems. We haven't talked about it. We haven't done anything yet.
All right, so I'm going to ask a hard question. Can we do anything about it before the things that you talked about that are, upstream are addressed? Are you, I know that you're working in this space, but I'm going to be, and people who watch this regularly know I'm not the most optimistic person in these conversations. As I think, I study these broad issues, and the depth and breadth of the issue is really daunting. I'll just say it that way. Um, are what we're doing when we talk about healthcare at the social level, are we really talking about better band-aids?
Yeah, no, I appreciate the question. I think about this all the time. And so I think the answer is yes, and I will beg your indulgence a little bit, and try to draw an analogy, which I just to be clear, I'm not equating the work that we're doing with the work of so I think about Brian Stevenson, and the work that he's done with the Equal Justice Initiative, as an aspiration, frankly, for myself and for my colleagues in this space. So for those who have kind of been familiar with his work, he started as a lawyer, defending Black men who'd been wrongfully convicted of murder, who were on death row, and one person at a time, using the tools of the legal system to bring truth to light and to change individual people's lives, and in small but really important and meaningful ways, like making a real dent in the problem, changing the arc for individuals. Mm-hmm. What he recognized really early on, and I think his team recognized, was that in order to actually change the problem at its root, they had to get way upstream. And that, in that instance, meant exposing and making clear the link between what we see right now, mass incarceration of Black and brown men, all the way back to slavery and lynching, and the legacy of slavery in our society, and how it shows up in the judicial system. And you make that connection, and then you start to work on that problem by drawing attention, by leveraging resources, by activism, and by starting to mobilize a much broader group of stakeholders around this underlying issue. And you have to do both. I'm a practitioner. I can't, I have a tool. I know how to take care of really sick people who've been marginalized and neglected from the healthcare system. I can mobilize people to do that. I can tell you with confidence that the work that we're doing to serve low-income, largely communities of color across a number of parts of this country is meaningful. It's providing tools and resources to folks who've had basically the worst of everything that our society has chosen to offer to them, and starting to make justice occur in small places. But that success for us means having these conversations. It means telling the story of how our systems and our societies fundamentally created the problems we're solving today, and how an overhaul of that underlying infrastructure is necessary for us to change the inexorable cycle of poverty, of injustice, of lack of access to tools and resources, all the way through, in this instance, as in the instance of Brian Stevenson's work, to somebody dying of something that they did not need to, should not have happened. And so I think the answer is yes, and, right? We've got to have these conversations. We've got to continue to lobby our policymakers. We've got to continue to mobilize resources. We've got to ask about how we embed anti-racism into all of our structural policies. And my hope is that in generations to come, people like me don't spend all of our time, seeing clinics full of people of color who are sick and hurting because of our systems and our society that created an inevitable set of circumstances that led to this day, right? And so we have to do both. It's our obligation to do so, and to be able to carry those two at once is, I think, part of what makes this movement actually powerful.
Mm-hmm. So I think of I thought the metaphor of Brian Stevenson's work is apt, because from my perspective, the space of healthcare and criminal justice are the places that you see maybe most dramatically the effects of race in this country. I mean, we really are talking about people's lives, right? It's not, education, um, economic opportunity, all those things are a part of living a good life. But when you see it in spaces where you're talking about depriving people of life, it really puts it into stark relief, the questions that we're discussing here. So I appreciate that metaphor. So I do want to talk a little bit more about your organization. So you can only attack part of the problem. You're only one person. So what is your organization designed to do, and how is it set up?
Yeah, so I'm really fortunate to be a co-founder of Cityblock Health, and we're set up to be a primary care, behavioral health, and social care provider. So we deliver health and social services to people who are largely marginalized in the healthcare system. This in the way that our system works tends to be folks who receive health insurance through Medicaid programs and through Medicare programs. So people who struggle with disabilities, mental health needs, social challenges, who are low income. And our goal is to radically transform the experience of care and the outcomes of care for these communities by investing differently in healthcare, taking what used to be a fee for service, you get paid to do more stuff to people type of system that favors reactive care, the emergency room visits, the CAT scans, the expensive surgeries that fix or attempt to fix problems once they've already occurred, and emphasizes instead what we call a value-based model of care that invests upfront in primary care and mental health and social services in the community to prevent all that stuff from happening in the back end anyway, and aligns our incentives around reducing spend, improving quality, and improving the experience of care for the folks that we serve.
Mm-hmm. And so you are a for-profit organization, right? Okay, so I've brought this up to you before, so you are ready for this question. There's clearly a at least a perceived tension between for-profit organizations and support of underserved populations, people of color in particular, right? So this is a part of what we were just talking about. There's all sorts of forces that push against positive outcomes for people of color, and people of color often don't really trust for-profit organizations that have their best interests at heart. And as you know, I'm sure much better than I do, there's not a lot of trust in the medical industry in communities of color. Why should people trust your organization?
Such a great question, and I appreciate it. I do. So a couple of things. I think the counterfactual and the status quo for many communities of color, low-income communities, is that healthcare is provided by nonprofit organizations that have a mission in mind that very much aligns with my mission, for sure, but that are reliant on funding streams that are not always sustainable, and often are tied to philanthropic resources, and often tie them to volume-based care. So this sort of fee-for-service engine that I described, they get paid to do more stuff to see people. And that doesn't drive trustworthiness often, nor does it drive sustainability. And so I actually came from that world. This is my first ever foray into a for-profit entity, and it was a deliberate choice. I was tired of feeling like care for low-income marginalized communities was a thing I had to beg for resources to do. Mm-hmm. It was a thing that was charity. And I was really interested in trying to understand, how do we take the tools and the systems and the structures and the resources, the tremendous amount of resources we spend on healthcare today, and create a sustainable business case for investing in these populations? Because I do believe that there is one. And I believe, as much as I wouldn't have designed it this way, I believe that it's our obligation to get access to those resources and invest them in these populations, and not have people have to say thank you and to be beholden to sort of charitable whims for that. Now, it's not to say that I don't think that there's a really important opportunity to do really important philanthropic work in these communities. It is that I believe that we're missing an opportunity if we don't take advantage of this lever and of this tool, which is to create a real business case for doing this at scale. On the question around trust, I think it certainly ties to what's your intent and what's your kind of, how are you originating into this space, and so that's important. What I find and what we're finding with our communities is folks already know that that healthcare is operated as a business. and the experience of healthcare. That's because we've decided in this country that we're going to allocate healthcare through a marketplace, with all of the failures that that marketplace contains. But that's what we've decided. That is how healthcare is administered today. So folks know that. It's better actually to be able to be transparent about this and about the fact that our incentives are aligned around my members' incentives, the people that we care for. They want to stay home and healthy and be in their communities. They want to spend more time with their kids. They don't want expensive surgeries and hospitalizations for things that we could have helped prevent. They want care that's responsive to them and that values and dignifies their experience. And they want a provider who doesn't get to be in business if our members don't come back to us. Like, I actually depend on creating an experience of care that is engaging and high value by the people we serve. That is how our business is successful. Mm-hmm. And so that alignment of incentives in many ways is advantageous and transparent, and allows us to really think about what matters to the folks that we're serving, not as charity cases, but as people who have purchasing power through their attention and their energy, and to create and to funnel resources that align around what their goals are.
Yeah, well, I appreciate that. I do agree that the idea of serving these communities as charity is problematic for a lot of reasons, thinking of it in that way. But there's another thing that occurs to me when you talk about this. In the private market, there are investors, especially in a for-profit organization. And there's one way to read this where investors are going to make money off the problem of racism, right? Mm-hmm. So that racism is producing the problem that's creating the opportunity to profit. Like, how do you think about that?
I think that is true for our system of racialized capitalism in this country. There is not a single institution mm-hmm. that returns to its shareholders that in some way does not benefit on the delta between the haves and have-nots. And that delta, in many parts, contains the legacy of racism. Mm-hmm. I don't know what else to say about that. I mean,
I hear you. It is crazy to think of it that way, that you have an organization that is designed to redress generations of racial inequity, and in doing so creates profits on basically I'd argue like the purposeful inefficiencies. It creates profit off that goes into people's pockets. There's just something like there's something that's so crazy about that. And you're right, that's how the system is set up. But it's in your case, it's so clear and transparent that that's what's happening because of your interest in serving the community and doing it through a for-profit way. Otherwise, usually it's just hidden. You don't see it, right? So there's something in my mind that's stark about seeing that profit generated as a function of the problem of racism.
Yeah, I mean, I think another way to so our organization exists to invest resources in returning value to both the patients that we serve, who I mean, I'm the first to tell you, so many of their problems are a sequelae of systemic racism. Mm-hmm. They're also a sequelae of a whole host of social factors that tie to education, that tie to income, that tie to access to resources upstream of this. And our goal is to impact those positively for the people that we serve. Mm-hmm. And also, until we as a society collectively get way upstream and start to ask why these problems exist, why these problems disproportionately impact communities of color, there is no way to extract those two things, to separate those two things. There is no way to do that.
Mm-hmm. Yeah, I appreciate your pragmatism on this. I'll just I'll say it in that way. And the other thing I want to think about is how is the community involved? Because there's, especially in the non-for-profit world, there's been a growing backlash against the kind of savior complex. I think you were alluding to it a little bit, where people from the outside come in and try to fix the community or serve this community they're not directly a part of. You see this in the backlash, say international aid is most clearly voiced, I think. But you also see it in some of the even recent local debacles, like in Pittsburgh, where you had people who really didn't understand the community they were serving come in and try to provide vaccines and testing into underserved populations and do a terrible job, basically implode. So I wonder, how do you think about community involvement in your organization?
Yeah, absolutely. I think there's a lot of those two examples have a lot there, right? Like, so the Pittsburgh example, I might take off the table because there was some other stuff going on there. So it's really
Fair, fair.
there's a lot there, but point well taken. So I think there's a couple things. I think the first is again, this is our business model is tied to our ability to meet people where they are, build trust with them, individuals, and be able to understand what's going on for them, intervene with healthcare services that make a difference to them and help change their outcomes. And we can only do that if we're able to do the first few things. It's like find you, build a trusted relationship, and understand what's going on for you. And so we think about community involvement on a couple of levels. The first is just making sure that our teams actually reflect the communities that we serve. So hiring folks from the communities we serve, and really leveraging their expertise in their community to help us understand what we can and should be doing for the people that we serve. The second layer is around engaging and leveraging community resources where they exist. And so I think we often talk and think about these communities as lacking. It's always from a deficits perspective, right? We talk about social determinants and social drivers and social challenges, and it's always this sort of idea that there's so much lacking. And what we find is that there's also so much already happening. There's a ton of power and resiliency in these communities. There are lots of organizations that have been doing work to serve their communities, that have the trust of their community members. And we are much better off partnering with them, following their lead, and humbly asking their permission to participate in the ecosystem that they've been creating and generating over time. And that takes time, and it takes intentionality, and it takes some creativity in thinking about how you bring those types of organizations into the value chain, so that we're creating incentives and rewarding and sort of partnering in a way that's beneficial to them as well. And so, I certainly wouldn't say we've solved it all in every community, but we're certainly understand the value, and are learning our way towards that with the support of community partners in every market that we operate in.
Yeah, and I see that that's a necessity given what you're doing in the model, right? There has to be some community involvement for it to work. And I also wonder about accountability. So, especially in a for-profit organization, at some point, investors demand returns. There's a desire for growth. There's all these pressures to find more and more efficiencies and increase revenue or profitability. How do you build accountability into your organization, or do you build accountability into the organization? So, um, and then this is an interesting situation where I'm more worried about the success than about the failure, right? So, what does success produce, and does it shift the shift what happens in a way that is against what you're trying to do, right? Does it change the way the organization operates, to the detriment of the people it's designed to serve? So, how do you think about accountability in your organization?
Yeah, there's a couple of levels there, but I would love to just unpack or better understand what you mean by the latter part of the question. But I'll answer the first part. So this is healthcare, right? And so we're accountable to impact and outcomes,
Mm.
to making sure that we meet our members, we serve them, and we are providing the kind of care with a level of quality that would make us proud. And that exceeds benchmarks in the market. So there's an accountability around the sort of quality of service and the outcomes driven by the service that I think is really helpful. And to your point, I think we don't always see that throughout the healthcare ecosystem. I think that's why I'm so grateful and really enjoy being on the service provision side. As a healthcare provider of primary care and mental health and social care, like there are clear benchmarks about what success looks like from a quality perspective. So that's one piece. I think the second that you alluded to is what's the relationship with investors and their expectations for returns. And that's where we've been really thoughtful about who we bring around the table. We have a mission and a mandate to have impact and to create scale, because I believe that by challenging the sort of status quo and the tacit acceptance that we as a society have about the idea that poor and marginalized communities will just get what they get, and it will be sub-quality, and it will look like homogenous, and it will be inaccessible. The only way to challenge that is by providing care that is the opposite of that, that's respectful, that is accessible, that drives quality outcomes, that is tailored and tuned to the needs of the population we're trying to serve, and that is investing intentionally against those types of outcomes. But you have to do it at scale to be able for anybody to sit up and take notice. And so we're much more interested as an organization, as a company, in building that scale and having that impact than we are on, a quick return. And our investors understand that there's a long game here, and there's a really big opportunity to build something that is impactful at scale.
Yeah. See, I mean, I was just to unpack it a little bit. I was just asking, how do you guard against movement toward I think you just see this in a lot of organizations that come into underserved communities, because there are not a lot of alternatives. They can be extractive, right? And I think that sometimes that can happen, not because people come in and are necessarily trying to prey on the community. It's just that you start to inch more and more toward how do we do a better job, but a better job is defined in terms of a better job for the organization, right? And I think there can be this slippery slope where you end up in an extractive position, although that wasn't your intent. And I was just wondering, how do you make sure that doesn't happen, right? So, and it sounds like you're saying part of it is the investors you have in, and part of it is the outcomes that you judge the organization on. Is that right?
Yeah, I think that's right. And so I think, a big part of this is the alignment around value and value-based outcomes. So it is, just to sort of give you an outline of sort of how our economics work, right? Like, it's very easy, to your point, where there's not a lot of options to set up shop and in a community and provide what you provide, and you get paid irrespective, right? You open your doors, people come in because they have no other choice. They may not feel good when they leave. They may not feel like they were treated with respect or dignity, but like, you're the only choice, you're the only shop in town. And in many instances, honestly, that's how healthcare has operated for a really long time. And so I get it. That's what fee-for-service creates, particularly in communities where there's scarcity. And I think what's different about, and what's important to us about that alignment with value-based outcomes, is that we don't get paid just for providing like doses of healthcare to people. I only get paid if things change for the person that we're serving. I only get paid if they make different choices, they are able to access different resources, they get healthier, they're staying home more than being in the hospital. Like, I only get paid if that is true. And that means my incentives are to align the care that I provide with what people say they want, and to create a relationship and an experience that's longitudinal and sustained. I care if they come back. I care if they pick up the phone when I call them again. And if you get treated badly, you're not doing that. Like, you're out and you're doing something else. And so I do think that there's some baked in alignment around our reimbursement model that is intentional around really delivering value for people, the way that they measure value for themselves. And that's why, as an example, when we look at satisfaction or a net promoter score, that's a key leading indicator for us. And we strive for a net promoter score of 90 amongst our populations, which is orders of magnitude higher than what you see in healthcare, where we're talking in the teens sometimes. And that's a first. I to this day don't know of any other healthcare organization primarily serving Medicaid populations that will even tell you what their NPS is, let alone have one that's on par with some of the sort of shiniest consumer brands out there. And that's because it's not a nice to have, it's a must have for success of our model.
Yeah, well, I'll say I'm happy you're doing the work you're doing, and I hope it continues to grow and you have great success for mostly for the communities, but also for you. So thank you for that work. And thanks for taking the time to talk to us too. I really appreciate your time today.
Thank you. Thanks for having me.
Yeah, and for everyone that listens, this is our last webinar of the season. I hope you enjoyed it. We will be back. We plan to be back next fall with a different season. If you enjoyed this show, please download the podcast wherever you listen to your podcasts, and have a great week.